Chairperson,
On
sir,
the lighter side, I think linagliptin was born in your clinic.
No, I think they should be paying me some copyright this thing they haven't so far. So amongst other issues, that's another one I'm taking to the court. So, um, well, diabetes and oral health. Time we opened our mouth about it. I am contracted for this talk by Colgate, and the idea here is to bring about the awareness on this bidirectional link. So we talk about chronic, highly prevalent, coexistent, comorbid conditions between periodontitis and diabetes. Now, honestly, yes, this is Sunday morning. We barely have a few people here. But if I look at the chairpersons and anybody in the room, how aware have we been about this link between periodontitis and diabetes? So when I started getting aware and started working with the Periodontal Society about 3 years back, realized that there is a lot of comorbid and a bidirectional link between these two disease conditions, often ignored by most of us, and hence the need to create more awareness on this problem. Well, this, of course, is a global burden of diabetes. A lot has been spoken about it, World Diabetes Day today. This data, in fact, is old, and some of you may be aware that we have had the new IDF data already come out, which would be released in December, but we already have the numbers, and the numbers are much higher. We talked today about almost 530 million people across the globe with diabetes today. Diabetes is a huge financial burden to the self, patient, and to the economy of any country. The prevalence of periodontitis currently, the prevalence of severe odontitis is about 11.2%, approximately 743 million people affected. So the number of people actually suffering from periodontitis across the world is much higher than the number of people who are suffering with diabetes. Periodontitis is the 6th most prevalent disease worldwide, and from 1990 to 2010, there has been again an exponential increase by almost 57%. What about the economic strata? Well, as we may guess, there continues to be an inverse relation. People from the poor class or lower socioeconomical strata, because of poor oral dental hygiene, tend to have a higher incidence of this disease, and hence the low-income individuals have the increased chance of periodontitis. Greater prevalence seen in the older age groups, again the chronicity, probably related to comorbid conditions. So as the age advances, we can see much higher prevalence of the periodontal disease here. We move to quickly talk about the bidirectional link. So this was the on World Diabetes Day, exactly a year back, we actually launched the clinical guidelines, which was titled The Management of Periodontal Disease in Patients with Diabetes. This was jointly published by the Indian Society of Periodontology, and it was also published by the RSSDI in the International Journal of Diabetes in Developing Countries, and was happy to be a part of this author group which worked on this guideline. So this is where it was published in the ISP journal and also in the RSSDI journal, which is the International Journal of Diabetes in Developing Countries. Then the two chronic diseases adversely affect each other. Poorly controlled diabetes is a strong predictor for periodontal disease. At the same time, periodontal disease and its severity actually impact the pathogenesis of diabetes, the control in diabetes, and the worsening of any diabetes-related complications as well. Now, this is a small study which looked at the influence of glycemic control in maintaining a good periodontal status. Prospective cohort with participants undergoing periodontal maintenance therapy. You had 92 individuals. Sorry, diabetes control assessment. You looked at the HbA1c, and what was found that out of this 92 individuals in the study, 23 had poor glycemic status, 23 had good glycemic control, and 46 had no presence of diabetes. In their clinical assessments, they had a full mouth periodontal examination which was performed at all the periodontal maintenance therapy visits during a 5-year interval, which included looking at what the dentists do, which is bleeding on probing, the depth of the probing, and clinical attachment level of the gums to the teeth or the periodontal area. Now, this result from this small study, the numbers were small, but the duration was long. It showed that glycemic control actually influences the good periodontal status. You look at the baseline and the final examination, which was after the 5-year period, and you see for every parameter, whether it is the change in probing depth, the clinical attachment loss, the bleeding on probing, Those individuals in blue who had poor glycemic control fared far poorly as compared to the ones with good glycemic control. In fact, when you have diabetes with good glycemic control, in terms of the periodontal measures, they scored as well as somebody without diabetes. And hence the need for people with diabetes, amongst other things, to maintain good glycemic control, to even have good dental health or oral health. So poorly controlled diabetes is a strong predictor of periodontal disease. Poorly controlled diabetes would lead to significantly worsening of the periodontal disease, increased risk of tooth loss. At the same time, good glycemic control would lead to consistent maintenance of glycemic level, which is shown, which improves overall periodontal health. So clearly a bidirectional link. If you have good control in glycemia, it will also lead to good oral health. Also evidence which has shown that not only diabetes, but pre-diabetes is also having a link with periodontal disease. So in patients with pre-diabetes, there was higher periodontal parameters, strong association with bleeding on probing seen even in patients with pre-diabetes. In fact, now the dentists have been made aware that when they are checking a person who says, I have no history of diabetes, and they find these periodontal signs, they have started asking these individuals to screen them for diabetes, or if some of them even are having to started keeping glucose meters in their dental clinics, they are beginning to check themselves. So bacterial dysbiosis in periodontal disease may contribute to pre-diabetes development. So the theory behind this is, when you have bacterial dysbiosis with poor oral health, there is a lot of inflammatory milieu. That inflammation is leading to, as a cause, as a pathophysiological cause towards development of pre-diabetes and diabetes. So screening pre-diabetes risk test is a useful tool that can be used for suspected diabetes patients visiting dental clinics. We've seen here there is a lot of publicity of the Indian Diabetes Risk Score by Dr. Mohan and RSSDI and USV collaborating. Probably time for us to start doing that in the general population. Periodontal disease affects the pathogenesis of diabetes. The evidence link that we have is periodontitis adversely affects glycemic control, diabetes complications worsen, and it promotes the development of type 2 diabetes. People with poor periodontal health and type 2 diabetes at a greater risk of developing overall worsening of glycemic control. Patients with severe periodontitis might increase the incidence of developing type 2 diabetes. So strong link between oral health and diabetes control. What really happens, if you see that closely, severe periodontitis worsens diabetes. As we can appreciate here, there is increased risk of hyperglycemia. Of course, this is going to lead to increased HbA1c and associated overall with higher complications. On the other hand, poorly controlled diabetes is a strong predictor of periodontal disease. So chronic periodontitis may be a risk factor for development of type 2 diabetes, and patients with periodontitis are at increased risk of impaired glycemic control. So all this evidence has been published in this paper, and we've been constantly talking about the dual risk and the bidirectional ring. You further look at the risk factors and the disease progression. What's really happening? So in patients with poor control, there is certain aspect of subgingival microbiota and biofilms, what we call in periodontitis. So there is bacteremia, there is inflammatory response, and there is an immune response to the same, leading to the inflammatory markers being present, or the inflammatory cytokines, etc., which are then released at the level of the gingiva. Now this is seen in both diabetes and periodontitis. So it's almost like when we talk about diabetes and hypertension, the common soil hypothesis, there is a separate common soil hypothesis for the generation of periodontitis and diabetes. A lot of people today believe that it's actually in our mouth, in the gum area, that there could be an origin of this inflammatory milieu leading to both these diseases. We look at the host-derived inflammatory mediators. Well, you typically have the neutrophil migration, you have complement activation, antibody production, release of cytokines, various ones. It could be TNF-alpha, prostaglandins, and host-derived cytokines. So multiple host defense mechanisms act together to eliminate the periodontal infection. That's the natural defense in the body. The inflammatory response connects the pathophysiological pathways between diabetes and periodontitis. And clearly here we talk about the influence of markers like TNF-alpha, macrophage inhibiting cytokines, the MIC, the interleukin-1 and the interleukin-C as the markers which create the inflammatory milieu. Elevated inflammatory markers then lead to a cascade of events. So we talk about what happens. There is inflammation, the body will have a response, there will be presence of inflammatory markers, and we talk about all these TNF-alpha, MIC, IL-1, IL-6. This, along with the impact of the periodontal microbiota, overall then leads to acute phase proteins released being there, the acute phase proteins being released like CRP, which further leads to the activation of oxidative stress pathways. This, the oxidative stress or the release of the oxygen-free radicals creates further worsening of insulin resistance or impairs the insulin signaling. This will eventually lead to hyperglycemia and may lead to onset of pre-diabetes, onset of diabetes, or worsening of diabetes and complications in those with known diabetes. Periodontal progression further leads to destruction of the bone, and that's where the problem worsens. As we can see here, the destruction of the bone in the teeth that they start experiencing. So inflammatory mediators in the gingival tissues activate the pathways that lead to bone resorption. And there is also destruction of the extracellular matrix, as pointed out here, with the collagenases, gelatinase, and all these, substances which are leading to destruction in the extracellular matrix. Now, as physicians, we've hardly had any understanding of the oral cavity and the dentition. The dental training at least includes them coming into the medical colleges and getting some training in anatomy, physiology. I don't remember doing my MBBS, hardly ever going to the dental side of the thing. So we don't get much exposure to even understand what's happening there. They get some basic understanding which is required. So I think we are extremely ill-equipped to understand what's really happening in the dentition and the gums and the gingiva. And hence it's important that we start paying a little attention. So if I have to sum up this bidirectional link, the link between diabetes and periodontal disease is triggered by a triad of inflammation, immune response, and dysbiosis. Inflammatory mediators cause periodontal destruction. The inflammation can lead to insulin resistance, worsening glycemic control. Diabetes impacts periodontitis. Diabetes patients are 3 times higher risk of periodontitis than normal individuals. Uncontrolled diabetes increases the risk of periodontitis. The increased risk is of both onset and progression. Longer the diabetes, more severe may be the chance of periodontitis. The other side, we look at how periodontitis is impacting diabetes. Presence of periodontitis results in poor glycemic control. This could in fact be considered as an early indicator of even pre-diabetes and diabetes, can facilitate progression or worsening of diabetes and increases the risk of complications. Finally, let me end by saying what is the interprofessional responsibility that we talk about. The role of physicians. Patients with diabetes should be referred for an oral health assessment as part of the overall evaluation. Today we have a list of things that we need to do on an annual basis. You're talking about foot examination, retina to be checked, your lipid profile, renal function, but we are not talking about the need for an oral. You and me are not equipped to look into the mouth and pick up things. We need our patients to see their dentist at least once a year. Physicians should seek evidence for the presence of oral health problems, and very often it could be periodontitis, which is the result why your patients are not reaching target control. We know that in spite of our efforts, less than 20% of our patients are at HbA1c of 7. We are increasing the medications, we are increasing insulin, but not realizing that there could be something like periodontitis, which could be a big contributor, and hence the need for all your at least uncontrolled patients to start thinking about that. Assist their dental colleagues by providing the results of lab tests such as HbA1c. Dentists can use this information to assess risk of progressive periodontal destruction, and they can also use HbA1c results to help assess the risk of hypoglycemia during any of the procedures that they may do in the clinic. At the same time, what is it that the dentist friends need to do? Evaluate patients for signs and symptoms of diabetes and then refer them to a physician, diabetologist, endocrinologist for further evaluation and diagnosis. They should at least start asking the patients for detailed family history of diabetes and should inform physicians about any oral signs of infection or other problems that may affect glycemic control. So the dental community, you know, that will very often call you up or ask you that this is the patient, is he or she fit? I don't think we have ever maintained that kind of. So I think there is a time that this bidirectional link is waking us up to our interprofessional responsibilities. So with that, let me end the talk.